Good evening and welcome to First Say Chats by Dr. G. I'm Dr. Adana Grandison, a physician in Barbados and your hostess for this evening. First Say Chats by Dr. G is a live podcast that provides listeners with a unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. And this evening, our episode is entitled Postmenopausal Bleeding, a Reason for Concern. And our guest is Dr. Felix Gittins. Dr. Gittins is a consultant obstetrician gynecologist who has been practicing medicine for the past 13 years. He is a graduate of the University of the West Indies, a member of the Barbados Association of Obstetricians and Gynecologists, and a fellow of the American College of Obstetrics and Gynecology. He is the founder and director of Gina's Women's Medical Services Inc., a women's health and wellness center in Barbados. Dr. Gittins is a proud father, husband, brother, and son. Good evening and welcome, Dr. Gittins.
Hello, good evening.
Good evening, Dr. Gittins. Thank you for joining us this evening.
Thank you for having me. Good evening to everyone.
Great. So this evening we wanted to really discuss postmenopausal bleeding. But I guess we could probably start the conversation on what really is menopause.
Okay, so let's get things started. We'll talk a little bit about what menopause is and how you know that you're going through menopause. And then afterward, we go through a little bit about postmenopausal bleeding, which is bleeding from the vagina or PV bleeding after you've gone through your menopause. So we get to talking about menopause first and then a little bit about postmenopausal bleeding. So just hi to everyone again. I am Dr. Felix Gittins, and thank you, Adana, for your lovely introduction. I am also affectionately known as Dr. G, but the original Dr. G, but we won't get into that. But let's go, and feel free to send in your questions or comments as we go along, and we try to address everyone as quickly and as soon as we can. All right, so let's define what menopause is. Now, it's pretty much a point in time which occurs 1 year after your periods have stopped. And this is because of the loss of ovarian function. It's very important to note that it's because of the loss of ovarian function, because periods can stop for many other things. So your period can stop if you've had surgery or if you're on a certain type of medication. But pretty much once the ovaries have stopped functioning, then you are going through menopause. And that usually happens after a year. The average age in Barbados of menopause is between 48 to 55. Most women tend to go through in the late 40s, early 50s, can be late. Often it's usually when your mom went through menopause. So if you found your mother went through menopause when she was 50, then you might start to go through those changes when you're 50. And we'll go through in a little bit what that's about. But it describes the time after that point. So it's been a year or more and you haven't seen your periods, you're now in your postmenopausal era. Now, menopause, usually when you go through menopause, it can either be that you've had surgery that removes your ovaries for whatever reason, and that puts you into menopause. Sometimes it can be certain medications that you're taking to help with other ailments that you may have, whether it be endometriosis or something like that, and that can put you into menopause as well, or it happens naturally over time. Some women go through menopause very early, what we call a premature menopause, and that's also something that you can be mindful of. So we'll discuss the symptoms for in order to diagnose or to say, okay, I am menopausal or I've gone through menopause. The major one, of course, is not having a period. So you're accustomed to having a period every month, and all of a sudden your period tends to skip months or it tends to be lighter or shorter. And then sometimes it doesn't come at all. 1 month, then 2 months, then maybe 6 months. And then after a year, and then you can say that's menopause. During that time period, it's called the climacteric. That's just the period where you're perimenopausal and you may start to develop certain symptoms. Now, menopause affects the body on a whole. So when we say you get symptoms, it can occur anywhere from head to toe. It affects all systems in the body, all your nerves. It can affect things like your vision, can affect things like your hearing, so your senses can also be affected. The most common one is hot flashes. You're sitting at home, everybody's fine. You might even be in an air conditioned room, the fan's on, and all of a sudden you start to sweat, and everyone looks around like, why are you getting beads of sweat? Or why are your clothes getting wet? Yeah, so the hot flashes are the most common thing. And this pretty much is because of a lack of estrogen or the female hormone, which is produced by the ovaries. So in your younger years, when the ovaries are active, the estrogen is produced, by the ovaries. It goes through a cycle. You get your menstrual cycle because the ovaries, you release an egg and so on from the ovary, you ovulate, and then you get your cycle. But when menopause occurs and the ovaries stop functioning, the estrogen levels are very low. And because of that, not only is there no period, but then you get other symptoms, including these hot flashes and other things that we call vasomotor symptoms. Yeah, so it's associated with things like insomnia, irritability, or more irritability, or more so than normal irritability, which can happen in our population, especially in these times. But irritability is very common, and feeling as though things are crawling on your skin, decreased sex drive, vaginal dryness. There are many, many symptoms, or an array of symptoms. It can even lead you to gain weight. Yeah, it can lead you to have an increased appetite, slow down your metabolism. There's so many different things that could happen. The main thing is to be able to identify those symptoms and to realize that it's something natural. It doesn't mean that you're necessarily ill, but you're going through a normal process of the cycle of life. And there are ways and things that you can do to help you to enjoy that. Now, that being said, remember, when irritable, one of the things you have to do is explain to the other people around you, not necessarily males, but other females as well, this is what's happening. It's not something embarrassing, it's something natural, it's part of life, and it is an explanation sometimes for why you are irritable or behaving the way you do. Other things can be insomnia, amnesia, which we spoke about the insomnia before, not being able to sleep, but amnesia or being very forgetful. And of course, osteoporosis, which is when your bones tend to get a little bit more brittle because of the lack of estrogen, and you're more prone to things like fractures and arthritic pains and aches and so on. Okay. So, in order to diagnose it formally, you can get a blood test that can look for these levels of estrogen and see that they're very, very low. There are other hormones from the ovary as well, but you can see that they're very, very low, and that can cause you to have problems as well. So, you can also check liver function, kidney function, check the thyroid, rule out other causes for feeling the way you do, and also check the vaginal pH, which usually helps you to know if you are going through menopause. Now, I see there are some questions here.
Yes, we have our first question from Melissa Starr. She says, "Please
Mhm.
explain surgical menopause with the right ovary intact."
Okay, so I guess that means, Melissa, that the left ovary had been removed for whatever reason. But usually, if you have surgery and the womb is removed and the ovary is removed, but one ovary is left back, when the womb is removed, or any surgery that involves the pelvis can sometimes compromise blood supply to an ovary. So even though the ovary is there, it may not be functioning as it would if you hadn't had any surgery.
Mhm.
So you can still get this premature ovarian failure where the ovary is present, but it's not functioning as it should. So you can check your levels of estrogen to see. That would be a good way to tell and confirm that the ovary isn't functioning the way it should. Other hormones as well, something called FSH or follicular stimulating hormone, but you can get a hormonal test done, and that will show you that even though the ovary is there, it's not functioning as it should, and therefore you would still get the symptoms of menopause because of the low estrogen levels.
Great, thank
Okay.
you.
All
Dr.
right.
Gittins, tell us
Mhm.
a bit about postmenopausal bleeding.
All right. So we're going to get into postmenopausal bleeding now. That's when, as we said, you've gone through menopause, you've confirmed it either with your blood test or you've had the symptoms, and then all of a sudden you have vaginal bleeding. It may be that you go to the bathroom to pass the urine, you wipe, and you see something pinkish or some blood on the napkin. It may be after sexual intercourse. It may be after some form of trauma, lifting something heavy. There are different reasons why this bleeding can occur. But when you do see it, it is, and no real pun intended, but it is a red flag. It means that you need to go and see your obstetrician and gynecologist as soon as possible, or your family doctor. But you do need to see a doctor when it happens because it is not a regular or normal occurrence.
And
Now,
Dr.
go
Goodman,
ahead.
just wanted to
Mhm.
interject. I am happy that you actually brought up that it can be something from a very light pink color to a very heavy bleed.
Yeah.
Is this something that usually occurs? Is it that persons more so will have a heavy bleed, or even with that light pink color, that blush color, they should be concerned?
Yeah, even with that light pink color or that blush color, you should be concerned. And what you want to confirm is that it is in fact coming from the vagina. So a
Right.
lot of the times you may wipe and it may be associated with your urinary tract or your urethra, or it may be associated with the rectum or PR bleeding. For example, you may have hemorrhoids. They've had a difficult time defecating or passing stool, and then you realize there's a little bleed, or it may have been a bit of trauma. So the first thing you want to do is confirm that it is in fact coming from the vagina. One of the ways you can do that is by visiting your doctor, especially when you think it's happening or at the point if you can, and they can do an examination for you to check and see that it's coming from the vagina or to identify where it's coming from. If not, then if you do use tampons, you can use the tampon for a few hours or half an hour, depending, but you can use that, then take it out to see if that is soiled, and then you'd know, okay, this is coming from the vagina. It's not coming from anywhere else in the genital region. And that's very important because sometimes you can have bleeding from sores on the outside of the vagina. You could have gotten a cut while shaving or waxing or something, and that can present as blood in your underwear or on a panty shield or liner or something, and that can also be confusing. Okay? So it's very important to note where the bleeding is coming from, and any bleeding at all should be investigated in the postmenopausal period. I mean,
Okay. So you were telling us about some of these causes of postmenopausal
yes.
bleed.
So some of the more benign causes are things such as vaginal atrophy, or what we call atrophic vaginitis. Pretty much means because of the age and the lack of estrogen, the walls of the vagina aren't as moist and as elastic as they used to be. They're very thin. And for that reason, the skin can break easily and you can have bleeding. That's something that's benign. It's due to friction and changes in the hormonal levels, and something that can be remedied easily. But the main thing is to diagnose it. So it can be something as simple as that. And that usually happens after intercourse, after a rigorous exercise class, or something traumatic. Sometimes it might be coming from the cervix. So it's very important to make sure you stay up to date with your pap smears, because the bleeding, even though you are seeing it coming through the vagina, it may be cervical in origin. And if it's from the cervix, that could be due to anything from a polyp, which is also something benign, or benign growth, similar to something like a fibroid. All benign things, or it could be some sort of laceration, it could be some sort of ulcer. Worst case scenario is that there can be changes in the cervix associated with cervical cancer. So the main thing is to delineate where it's coming from and
Mm-hmm.
get that investigated. Okay, it could be secondary to trauma alone, just that you fell somewhere or you were riding a bike or something, and that happened. And yes, in this day and age, with the advent of many different forms of gratification by yourself, sometimes these things happen with certain toys, especially not if they're a little jagged or rugged or anything like that. That's actually a very common presentation for postmenopausal bleeding.
Okay.
So that's something to be aware of as well. That it can be self-inflicted, either not necessarily intentionally, but it can be self-inflicted as well.
Okay.
All right.
Great.
Yeah. So the
How?
main
Go ahead. Go ahead. Go
Right.
ahead.
So the main thing that we want to rule out when you're having postmenopausal bleeding is that there's no bleeding from inside the uterus or the lining of the womb or the endometrial lining or the endometrial cavity. If you have bleeding from the endometrium, when you're examined, you see blood coming out through the cervix as opposed to blood being in the vagina or anywhere else where you might have a bleed, or blood being on the outside of the vagina, for example, if there's a sore or ingrown hair or something like that. If it's coming from inside the lining of the womb, then that's when we want to rule out endometrial cancer. One of the things that we learn in school, or anybody who's growing up and when they're coming to do obstetrics and they're studying gynecology, once you have bleeding from in the postmenopausal period, you have to rule out endometrial cancer. That's one of the main things they have to do. And then by taking a history and speaking to you to find out what your risk factors are for the different types of cancer, then we can get an idea of if this is cancer. We can also do certain investigations to find out. Now, in the history, you're talking to you to find out if you are at risk of endometrial cancer. You'd ask things like if you had an early start to your period, if your menopause was later, if you've ever had any children. If you've never had any children, then that's a risk factor for developing endometrial cancer. If you had an early start to your period, if your period started when you were, say, 8 or 9 years old, or if your menopause happened, say, when you were age 60 or in your early 60s, as opposed to earlier than that, anything that has unopposed estrogen therapy. If you were taking some form of estrogen, whether it was for another type of disease or condition, say you've had breast cancer and you had to be on some sort of medication, there are different things that can predispose you to developing the endometrial cancers. But the majority of the times, most people, they don't really have any risk factor. They don't have any family history. They don't have any history of estrogen or estrogen therapy or hormone replacement therapy, and you can still have endometrial cancer. So that's why we do the test that we do in order to rule that out, because that is one of the major, or one of the causes, that if we do find that you have it, we have to move contain. Suppose menopausal bleeding might not be due to cancer, it might be due to something called hyperplasia, or changes in the cells in the lining of the wombs. And that's very important, because if left untreated or unchecked, within a few years, it's possible that it could develop into cancer. So early tells you, hey, I need to get this investigated. Sometimes it can be treated with medication. Other times it has to be something surgical. But either way, it's best to investigate it. And more often than not, it might be something totally benign. It might be a fibroid. It might be a polyp, which is just a very tiny, tiny, tiny fibroid, like the size of a pebble or smaller. It might be that the lining of the womb got very thin because of the changes in your age, and because of that, it started to bleed. There are many, many other reasons. So then you can go on to, after speaking and finding out the risk factors, you can go on to the investigations. But you want to say something, Adana?
Yeah, sure. How would one investigate specifically to make that distinction between hyperplasia, just generally, not too much in depth, distinction
Okay.
between endometrial hyperplasia and possibly endometrial cancer?
Okay.
What
So
should they be looking
the
for? Mhm.
yeah, with the history, if you do have cancer, it's the same as any other type of cancer. So you might tend to feel unwell. You may have a decreased appetite. You might start to lose weight. Your clothes might start to fit you differently. All these things will clue you into the fact that, okay, something's wrong. You might start to see your stomach starting to get bigger, in terms of your uterus might start to grow in size. So you might start to see your stomach getting bigger or bulging or feeling bloated. You might start to feel swellings in your groin area. You might start to feel sweat, which we call lymph nodes, and the bleeding might tend to be worse or get progressively worse and
Mhm.
become more frequent. So instead of bleeding and it stops, or it's just a little pink thing, it might then come back with maybe a small clot. It might bleed as heavy as you might think, oh wait, how come my period has come back? It might feel like it was an actual period that you had. So the bleeding might be a little bit heavier. But the best and the most definitive way to tell would be the investigations, as Dr. Grandison was asking about. So, first and foremost, you get your blood test done to confirm that you are, in fact, in menopause, if there's any doubt about that. And then we also check your hemoglobin, or your blood count, to assess how heavy you are bleeding to see if you've bled to the point that has made you anemic or you've lost a lot of blood. After that, then there is an ultrasound. The ultrasound is usually a transvaginal ultrasound, which is the one where they use a very tiny probe and insert into the vagina, and they look at the thickness of the endometrium, or what we might say the lining of your womb or the lining of the uterus. And we have certain cutoffs for people who are postmenopausal. So if it's more than 4 millimeters thick, then we consider that to be thick. If it has fluid, or if there's fluid in the endometrial cavity, you can see blood accumulating in there, then that's also a reason for concern. If the endometrial cavity or the lining of the endometrium is thick, then we go on to do an endometrial biopsy, which again is a procedure that can be done in the office, where you take a very small catheter, thread it through the cervix, and sample the lining of the uterus. This can be done sometimes under local block or sedation, especially if you have a very low pain threshold, but it's a very quick procedure. It can be done in office, and it's usually sent to a lab to be investigated to see what types of cells they are, whether you have this hyperplasia cells or precancer cells, or if they are in fact cancer cells. Bearing in mind, you can have this test done. The results can be normal. There are actually about 2% of people who, even though they get that test done, they are missed. So in the majority of people, you will find 98 out of 100 people, you will diagnose the problem or you will find the problem. But there are 2% of people whose problem still recurs or it persists. And in that case, then you go on to do further testing.
Mm-hmm.
Further testing now would include things like hysteroscopy, which is when you use a camera and thread it through the same way through the cervix and look into the cavity or into the lining of the womb and visualize and see if there's any reason why you're having bleeding, whether it's a polyp or a small growth, or whether the womb is very thick and you can see growths going on inside, and then you're able to take your biopsies. There's also a form of hysteroscopy or a form of ultrasound where you can use normal saline to help delineate the cavity of the lining of the womb. And that can also tell you what's going on, if it's irregular, if there's a growth, or what have you. So there are further invasive tests that you can do, but usually the sampling of the endometrium by doing the endometrial aspirate or something called a DNC or examination under anesthesia is usually very accurate and adequate. You can get a good specimen from the entire uterine cavity, send it to the histology lab, and that will let you know this is normal, this is a polyp, this is hyperplasia, or this is endometrial cancer, or cancer of the lining of the womb.
Okay, great. We have another question here from Marsha Jordan 32. If 30 millimeters of fluid is found in the endometrium in someone who has a fibroid, what does that mean?
Well, that can mean so many things, but it depends on the person's age. This other question is funny as well. It depends on the person's age, and whether or not they're menopausal or they're in their postmenopausal period. But fluid in the endometrium in general, if someone who has a fibroid, it's more than likely it is that the fibroid has degenerated or it has bled. Now,
Mm-hmm.
fibroids themselves can bleed from their surface. So if you have a fibroid and the location is one that it bulges into the endometrial cavity, and the surface of that fibroid bleeds for whatever reason, that it got irritated or it started to break down, then you can get fluid accumulating. That fluid can either be a clear fluid, what we call cystic fluid from cystic degeneration, or sometimes it can be blood. Fibroids tend to degenerate when they kind of outgrow their blood supply or they outgrow their hormonal supply, because they tend to feed off estrogen and off of blood supplies. So if the blood supply is outgrown, then the fibroid tends to degenerate. It doesn't mean that you're going to get pieces of fibroid coming out or falling out, but you can get some fluid depending on the type of degeneration. And sometimes too, it can make you feel a little bit unwell, and it can definitely cause you some pain, and that can result in the fluid being in the endometrial cavity. But that fluid could also be there if somebody was younger, they had fibroids and they were having a heavy period, or they were about to have a heavy period. So it depends on the patient, but more often than not, that much fluid, if you see that in the endometrial cavity, it's either that the fibroid has bled or it started to degenerate and you get that fluid collecting.
Okay, so really and truthfully, for a patient like this, it really requires more individualized attention that you should probably consult with your doctor to get a more complete answer because it also surrounds the history as well, correct?
Yes, definitely. So to manage your fibroids, yes, definitely. You have to find out, you have to get a little bit more information before you can definitely say what the cause is, but it is something that would need to be investigated.
Great. We have another question here, Dr. Gittins. How long can one go through menopause?
Again, that differs as well. We hope it's not too long. But there are many guys out there who might say that, their partners have been menopausal for years or postmenopausal for years because of the irritability symptom,
Right.
but it varies from person to person. And there are some people who, believe it or not, they would have their hot flashes and so on. For maybe there's some people who don't have any symptoms at all, and they would tell you, "Oh, I went through my change of life, as they call it, and it was a breeze. I had no problems." And there are other people who get really bad symptoms. Sometimes they last for a year, sometimes they last for 2 years, and then it goes away. And then you have a 5 year period where nothing happens. You're great, and then all of a sudden you find you get a hot flash again. Yeah, so it really depends on your levels of estrogen, your body's response to it, and then whether or not you're using any form of therapy to help with the menopausal symptoms. Whether it's estrogen replacement or whether it's some natural remedies, such as things like evening primrose or black cohosh or something else called red clover, things which have been shown via whatever medium, whether it's mental or actually physical, but they have been shown to help improve your symptoms and how you feel with regards to the menopause. So there are lots of different things as to why, but it's pretty much an individualized thing. So you can't say that one person that the period for postmenopause is 2 years and that's that. Some people it's 6 months, some people it's 3 years. It really just depends on you and how you manage your symptoms and what interventions you have or you put in place to help with the symptoms that you have of menopause.
Okay, we have another question or a comment really. I am 50
Mm.
years old and have an irregular period. Recently, I experienced bleeding for 12 days. Although it was relatively light, it was annoying. Is it something to be very worried about?
Okay, so I was gonna actually respond to that person by name, but then I saw. So what I will say is having an irregular period at 50 years old is also some reason for concern. And for that, we call it abnormal uterine bleeding or AUB, and then you try to find out what the cause is. So you have an irregular period, you're still having periods, you haven't gone through menopause yet, but sometimes it could be a fibroid or a polyp or changes on the cervix, so it should be investigated. It may not be anything sinister or anything to worry about, but you should have it investigated. Whether it's seeing your doctor and having your history taken and then having an examination and possibly an ultrasound as well to see if there are any irregularities. Once you rule out anything sinister, then you can say that. But abnormal uterine bleeding is also a reason or some cause for concern and for you to visit your gynecologist and have those investigations done, the history examination and the investigations done.
Great, thank you.
Yeah.
Another question. How long does surgical menopause last?
Well, again, it's individualized. So the symptoms of menopause, usually for surgical menopause, the symptoms come on very quickly because it's kind of an abrupt thing. And surgical menopause is when you pretty much have your ovaries removed surgically. So the source of estrogen is removed suddenly as opposed to going through it over a period of time like a year or a year and a half that we would have called the climacteric. So it's usually kind of like a plunge off the deep end into menopause very quickly. When that happens, you get symptoms very quickly, but in terms of how long they last, again, it depends on what you do to manage the symptoms. Some people are totally against hormone replacement therapy and they try to use other forms or other methods to manage their symptoms. But for surgical menopause, you do get symptoms pretty much within a few days of having had the surgical procedure done. And it is then to manage the symptoms and how you choose to manage the symptoms that would determine how long they would last or the severity of the symptoms. But in terms of timelines, the symptoms come on very quickly post the procedure, or after the procedure. And then in terms of how long the symptoms last, it really, again, is individualized and based on management.
Great. I have another question here from a Shirley. Are pap
Mhm.
smears necessary for menopausal patients?
Yes, well, pap smears now are recommended up until the age of 65 once they have all been normal. So once you don't have a family history or you don't have any history of having abnormal pap smears, then you get your pap smears regularly. Sometimes it's every 2 years, every 3 years, or every 5 years, depending on how your screening was done and whether or not you had other types of testing such as HPV and so on, and also on your lifestyle or lifestyle changes. But in general, once they're all normal and everything has been by the book in terms of your screening, after the age of 65, you don't need a pap smear anymore. Once they've all been normal up to that point and you've had your regular screening. That being said, they're not recommended anymore up until the age of 65. Some persons, still for peace of mind, or if they have a risk factor, or they have a friend or somebody who has had a bad experience or has had a close call with cervical cancer, might still wish to have them done, and that's okay. But in general, pap smears are really, once they've all been normal, after the age of 65 and they're still normal, you don't need that screening anymore. Because the time that it would take for you to then develop an abnormal pap smear and then cervical cancer would be something like between 30 and 40 years. So it'd be a very, very long time. So once your screens have been normal up to that point and you haven't changed partners, your lifestyle isn't one that would put you at risk, then you don't need to continue your pap smears after 65. So if you've been through menopause at age 50, then for those next 15 years, even though you are postmenopausal, you would still be getting your pap smears.
Okay,
Yeah.
great. If someone is on hormone replacement therapy, do they stand a chance of developing cancer?
Yeah, by cancer, I guess they mean endometrial cancer, which is what we've been speaking about, or cancer of the lining of the womb. And yes, you do stand a chance because estrogen is what can lead to endometrial cancer. If you have what we call unopposed estrogen therapy, which is just estrogen alone, and your uterus is still in, you haven't had a hysterectomy, so the lining of the womb is still there, the estrogen replacement that you're taking can affect the lining of the womb. So mostly when people go on hormone replacement therapy, it's a decision that has to be individualized and discussed with your gynecologist. And you have to start on, if you do decide to start on it, it's a very, very low dose or the lowest dose possible that helps to treat your symptoms. Usually persons who use hormone replacement therapy are people who have really, really bad symptoms of menopause to the point where it prevents them from functioning,
Mm-hmm.
whether it be something socially or something academically or work-wise. But if it prevents you from functioning, you need something, then you have a very low dose of hormone replacement therapy. And there are different routes of administering the hormone replacement therapy. It can be topical in the form of a cream. It can be in the form of injections. It can be in the form of tablets as well. So there are different ways that you can administer. It can also be, different various rings and implants and so on that are available now that can administer the hormones as well. But there are ways, and transdermal, such as patches and different things like that. So there are ways that you can do your hormone replacement therapy, but it has to be done under the watchful eye of your gynecologist. And then you have to be very careful if your uterus is still in to look out for signs such as bleeding, thickening of the lining of the uterus. And if you had a family history or you had a problem or any other risk factor that can add to that, then you'd have to be very careful as well. So it can be individualized, but unopposed estrogen can cause a problem. Some people get their estrogen with a little bit of progesterone, which is the other hormone, so that you can kind of counteract the effects so that it's not fully cancer causing or likely to cause cancer.
Right,
But unopposed estrogen is a very, very, very common risk factor, and a very high risk factor for developing endometrial cancer. So hormone replacement therapy, it has its uses, but again, it must be individualized and carefully decided upon between gynecologist and patient.
great. Now, you said that the majority of postmenopausal bleeds are benign, although they should be investigated. by your doctor. What are some of the potential treatment modalities, very wide in certain terms of general categories of treatment modalities that one may use to counteract some of these postmenopausal bleeds? Is it just a situation where you essentially would say, well, the bleed is not that heavy, let's just watch and wait? Or does the doctor intervene, and how so?
So you should never say that the bleeding is not that heavy. Let's just watch and wait. Again, we
Yes.
want to find out what the cause is, and some of these benign causes can then be treated very easily. So, if your benign cause is, for example, um, sore on the vagina, then that's something that can be treated easily. If your benign cause was atrophic vaginitis or it was an infection, then that infection can be treated and it would go away. Sometimes the infection, you can have a yeast infection that can be really bad and cause you to get cracks in the skin and so on. So then you treat that with the canesten ovules or what have you, whatever you use to treat an infection. So it really depends on the cause that you do the treatment. Now, Premarin cream is sometimes used for atrophic vaginitis. That is a form of estrogen cream that's topical, and that you don't have to use it every night. You can use it sometimes once a week, twice a week. That can also help. If it's because of any trauma or any friction, especially during intercourse, then there are certain lubricants that you can use, KY, whatever the lubricant is, make sure it's just something that's water-based, sometimes a little silicone, but definitely not oil-based. And you can use certain treatments such as those to help. So it really depends on what the cause is for the bleed. So once you identify the cause and it's a benign, if it was a polyp, it may be easily removed and that can stop the bleeding. So it really is cause driven or cause directed, but the main thing is to make sure that it's not something related to cancer. All right. Now, I don't know, we can go into a little bit about other benign causes because the hyperplasia can be either hyperplasia that's normal with normal cells or hyperplasia that's abnormal. When I say hyperplasia, I mean the changes in the cells in the lining of the womb. So they're not cancer cells, but the lining of the womb is thick because these cells are starting to overgrow or get hyper, and we call it hyperplasia. When that happens, you can treat that with something called progesterone. So it's not the estrogen, but it's progesterone therapy that helps to thin the lining of the womb. So it's a hormone as well, but not estrogen. It helps to thin out the lining of the womb. So most patients, if they have the bleeding and we realize this is postmenopausal bleeding, it's not cancer, but it's due to something called hyperplasia, you can simply get some progesterone therapy. Again, via many forms. It might be an injection, it might be a tablet, it might be in the form of a device that goes into the uterus, an intrauterine device called the Mirena. And there are different things that you can do to administer the progesterone. And then you have a repeat test or a repeat endometrial aspirate after about 6 months or so to see if the endometrium is still thick and if it still has the hyperplasia. And usually the treatment is very successful after 6 months.
Okay. I wanted to know, is postmenopausal bleeding usually painful?
No, it's not usually painful. Again, it brings it back to the cause, but sometimes it might be painless. Usually, if it's associated with a malignancy or a cancer or hyperplasia, it's painless. If it's associated with a sore on the vagina or like an ingrown hair, then it can be painful. If it's associated with fibroids that are degenerating, then that can be painful as well. If it's associated with trauma, then that would be painful too. So it really depends on the cause, but not all postmenopausal bleeding is painful. And the painless postmenopausal bleeding or painful should still be investigated and go through the usual steps of seeing your doctor and having the different investigations done.
Right. So really and truthfully, the real take home point that I'm hearing here is that any type of bleed that you have after the postmenopausal period should be investigated by your doctor. Your doctor will have that conversation with you, take a very robust history, try to get to the bottom of it, investigate you. First, make sure that it is even vaginal bleeding. But once we've decided that it's vaginal bleeding, then really investigate you to come to a possible diagnosis and then treat based upon that diagnosis. And that's certainly the majority of causes are benign, but we need to definitely make sure to rule out any endometrial cancer or endometrial hyperplasia.
Yes, yes.
Is
And
there
it's
anything
important
else?
to know.
Go ahead.
Go ahead, go ahead.
Go ahead.
Okay, right. So just important to know about hyperplasia, that the hyperplasia, because it might be a bit of a, people may not understand what you mean when you say hyperplasia, but it's just that the cells of the lining of the uterus are growing at a faster rate than you'd expect. So then when you do your ultrasound, the lining of the womb looks a little thicker. So it's not cancerous, but if left unattended, there's a possibility that it can become cancerous, and that is something that is treatable. Now, that being said, if you have hyperplasia with abnormal cells, or what we call atypical cells, then the therapy is a little different. As suppose instead of trying to give you medications, that therapy involves surgery, or it's a surgical option where it involves a hysterectomy.
Mm-hmm.
So we speak a little bit about what a hysterectomy is. That's when the womb is removed, and at that age, when your ovaries have already stopped functioning, the ovaries and tubes are removed as well. So it's called a total abdominal hysterectomy. So it's a surgical procedure where you get an incision kind of like along the line where you would have a C-section, if you've had a C-section before.
Or your bikini
And
line.
yes, or the
Okay.
bikini
Right.
line.
Right.
and the uterus is removed through that incision. The whole procedure probably takes about maybe an hour, 45 minutes or so. And it's done under general anesthesia. So you have to be admitted to the hospital. You have to get an anesthetist or a person who puts you to sleep. You have to get people to donate blood just in case, because there are risk factors as associated with any other type of surgery, the risk of bleeding and infection. But usually it has a very low complication rate. And it is a procedure where the entire womb is removed along with the ovaries and tubes, and they are all sent to the lab to confirm, okay, these cells in the lining of the womb are changing and they haven't spread or they haven't gotten any worse. But if they
Mm-hmm.
are atypical, there's a very high chance that they can become cancerous, or endometrial cancer, or cancer of the lining of the womb. So if you have an endometrial aspirate or some form of biopsy or sampling of the lining of the endometrium, and it does come back saying that there are atypical cells there, then the therapy would involve having a hysterectomy. If the cells are just atypical and you've had a hysterectomy, then you don't need to have anything after in terms of like chemotherapy or radiation or anything like that. The surgery alone is curative, which is why it's very important that if you see this bleeding early, that's one of the first warning signs. And if you go to your doctor early, you can avoid unpleasant things like having to have chemo and radiation and those types of things. It could be something that could be handled simply either with medication or by having a hysterectomy, and then that will be curative. It's only if these things are allowed to progress and endometrial cancer does develop that then that comes into play, staging and depending on spread to other parts of the body, and then chemo and radiation and so on.
Right. I see we have
Yeah.
some questions here from Aaliyah Y. In the unfortunate circumstances that the hyperplasia is not reduced, what would be the next step in management? And I think you were talking, that was from an earlier discussion you had.
Right. So if you have the hyperplasia without atypia, and that's not reduced with just the medication alone, then the medication we usually give you a 6 month interval. If it's not reduced with the medication alone, you have the option then of having a hysterectomy or of trying again for another 6 months. If after 12 months there's definitely no change and the hyperplasia is still there, then we recommend that you have a hysterectomy,
Okay.
which
Great.
is that you have the womb removed. So the hyperplasia is persisting no matter how much treatment you get. You keep doing over the test or the biopsy, and the hyperplasia is still there. It's still coming back as hyperplasia cells. Then you'll have to have. We recommend that you have a hysterectomy.
Okay. What is life like after treatment, hysterectomy, medical management? What is the quality of life like?
Well, the quality of life after hysterectomy. You speak about the hysterectomy first, because I know that's one
I know
a
you
lot of
can't
people might be.
I know you can't answer personally, but generally speaking, a lot of women are quite concerned about if I go and I have a hysterectomy, I'm taking away a part of my feminine, persona. It's part of
Yeah.
me. It makes me less of a woman. Tell us a bit about what and based upon some of your interactions with patients, what is the quality of life like after hysterectomy?
So after hysterectomy, yes, it is a part of you, and I can understand how you would feel having to lose a part, especially a part that defines you or that you feel it defines you as a woman. But there's still other parts of you that define you as a woman, and you know the reason why you've done it. So once you're comfortable and you know that the reason why you've done it is so that you can have a better quality of life and a longer life with your family, your children, your grandchildren, your friends, then you'd understand or that there'll be some sort of calming effect for you. But physically speaking, having had the hysterectomy, the change really is that there's no more bleeding because the womb isn't there for you to have any bleeding anymore. There are no more pap smears depending on what your age is because you removed the cervix as well. There's no risk for you to get cancer of the ovaries or cancer of the tubes because those are also removed if there was that potential risk. In terms of your sex drive, you would have already gone through menopause and already would have had symptoms of a lack of estrogen. So this is not now putting you into a surgical menopause. You're already postmenopausal. So sex now wouldn't be interrupted by bleeding. It wouldn't be interrupted by pain. And there are many medications out there that can help with feeling or increasing your libido or increasing your sex drive, especially now that the uterus or the lining of the womb has been removed. That there are many things out there now that you can use to enhance your life. So after hysterectomy, initially there's a recovery period where you're at home and you're, starting to do things for yourself after a few weeks. You're starting to cook, clean, and so on, but you can pretty much resume normal function. Sometimes nobody would even know that you've had it done. No one can tell that you've had it done. Only if you choose to tell them would they know that you've had it done. But looking at you, you wouldn't be able to see a difference apart from your tummy might be a little flatter, especially if your good doctor does a little tummy tuck for you as well, if that's indicated or if you want that done. And life afterward improves because you no longer have the symptoms of or the worry in your mind of this uterus, this bleeding, and whether or not there may be cancer. And you get definitive answers because everything that's removed is sent to the laboratory. All the cells are looked at very closely under the microscope so that we can tell you, okay, you've taken everything out. There are no cancer cells, or there were some cancer cells, but all have been removed, and you have nothing else to worry about where that's concerned.
Okay, I have another question here.
Yeah.
I've had cancer and doctors have not allowed hormonal treatment. I'm going through menopause and have every single symptom. It's bad. I've suffered from menorrhagia, I'm assuming, which is heavy bleeding. Can
Mhm.
you opt for surgical menopause?
Um, so this person, oh, they're going through menopause currently, and it depends on what cancer they've had before. I
Hmm.
don't, if it depends on the type of cancer that they've had.
So definitely, again, a more detailed
Yeah.
sit-down conversation to have with the doctor.
Yeah, with their doctor. But surgery is usually something that you don't jump to right away. You usually try other therapies first, and if there are contraindications or the other therapies can't be used for whatever reason, then you can't see that as an option. But more questions would have to be asked. She says her cancer was kidney,
Right. So
so
that's definitely a discussion to really have
eh,
with the doctor in terms of the risk and benefit, because certainly surgery in itself has its own risk, anesthetic
yes,
risk,
it
surgical
does.
risk. So it's a very robust discussion.
Yeah, it
Uh,
depends on her age and her comorbidities. There's so many other things, but
right.
it is an option, but something to be discussed.
Okay, great. Dr. Gittins, what are your take home points for us for this evening before we wrap up?
Okay, so before we wrap up, the definite take home points, if you have bleeding after you've gone through menopause, definitely need to see your gynecologist. It is a
Mm.
red flag. It can usually be something benign, but it can also be an early warning sign of something more sinister that can be treated either with medication, depending on what it is, or surgery. The main thing is to have it investigated, find out why you're having the bleeding, confirm that the bleeding is in fact coming from the vagina, find out why, and treat it abruptly and quickly before anything sinister such as cancer, develops or it starts to spread. Now, that being said, bear in mind that the treatments are ones which can improve your quality of life. They're ones which don't leave you feeling as though there's no end in sight or that there's no treatment. The treatments are usually ones that are very defining and that can answer your questions and pretty much give you peace of mind, as in to find out what has happened and why you're having the bleeding. So don't be alarmed, don't worry, but see your gynecologist, see your general practitioner, and get a referral if that's the case, but you need to be investigated for it.
Very good. Very good.
Yeah.
Dr. Gittins, I want to say thank you very much. This time went quite quickly. And I am sure that our listeners had lots of questions this evening and all of them were answered. So I want to say thank you so much for coming out and really answering our questions as it relates to postmenopausal bleeding. I know that sometimes this can be quite a taboo topic. Persons generally don't like to talk about it. But thank you for coming out. And once again, I want to say thank you to all of our listeners who participated in the message board. And I encourage you to follow us on both Podbean and Anchor and join us next week on First Aid Chats by Dr. G, Closing the Gap. Good evening. Thank you, Dr. Gittins.
Thank you, and good evening to everyone.
All right.